So I think we're ready to get started. I'd like to thank all of you in attendance for joining us today. We'll be hosting this webinar by Dr. Phil Westbrook, Dr. Richard Hamburg, and myself. I'm Dan Lindowski. So first I'd like to turn it over to Dr. Westbrook.
Thanks, Dan. Now one of the problems, as we, or perhaps I saw it, was a dependence on complex and expensive in-laboratory attended polysomnography for the evaluation of sleep disorders. We started our disruptive efforts with a system for the diagnosis of sleep-disordered breathing using a self-applied portable forehead recorder, the unicorder, in a system called the Apnea Risk Evaluation System, or ARIES. This system today is very widely used, over 250,000 patients currently, and growing rather rapidly. We have now recently developed a new portable system for in-home multi-night assessment of sleep architecture and continuity that we think has tremendous potential for both clinical use and, of course, for research. We'd like to discuss that system, the Sleep Profiler, with you today.
I only want to just comment that it is interesting to see those waveforms, and I was quite skeptical initially, having the belief that you couldn't possibly get those waveforms from the forehead, but I went through them with him, and you really do get them.
The Sleep Profiler system includes a physiologic data recorder worn on the forehead with a history and physical questionnaire and a sleep diary to obtain information useful in the interpretation of the study. The data are transferred, auto-scored, and then edited by a technician or physician. Multiple report formats are available, including a comparison between the objective and subjective sleep measures that helps to highlight sleep state misperception. The auto-scoring algorithms have been validated in 3 studies, and we've produced a scoring manual that helps users link the forehead signals to the American Academy of Sleep Medicine scoring criteria. We measure 3 channels of EEG from 3 forehead sensors. We use the traditional frequency band detection of sleep spindles and cortical arousals, plus detection of the magnitude and sharpness of the ocular activity to stage sleep into one of 6 categories. Pulse rate and pulse rate arousals, snoring, and head movement and position are also detected and marked. Sleep Profiler records neurology quality EEG. You can see in this example the low rollers associated with N1 plus the increased alpha activity highlighted by the arrows. This snapshot of N2 shows auto-detected spindles and an example of a K-complex. Similar to PSG, 20% of the epoch must include high-amplitude delta activity to be called stage N3. Delta power is attenuated by 50% on the forehead as compared to the central region. Here you can see the signature ocular activity during REM in the top example, and in the bottom, increased beta activity highlighted by the arrows that indicates REM when ocular activity is absent.
So we're going to move on to the clinical applications, but the reason for spending a little bit of time with you and showing the signals was simply to show that these are neurological quality EEG that you're getting, similar to what you would get in the lab. So I'd like to introduce Dr. Hamburg now, and he's going to take us through what he's been doing with the Sleep Profiler in his practice.
Hi, how are you? Thanks for having me. For me, most of my practice has been, obviously, like many of you, obstructive sleep apnea related. But as you have practiced for a while, you can't help but develop a percentage of patients that are interested or have the complaint of insomnia unrelated or combined with obstructive sleep apnea. One of the frustrations for me has always been the younger patients who were coming in to me interested in just receiving medication or drugs. I practice in New York, and sometimes you get patients that are not the most honest. I'm not in the city, but you still get patients that are looking for medications. And although, a good history is always adequate to probably really make the diagnosis, it's nice to have an objective test that you can now offer to these patients that, for one, defines, the problem that they have. Two, offers you kind of more of an interest in the entity. I mean, it can be, just a tiresome discussion of their complaints without having any objective measures. And, you get the drug reps that come by trying to push you to give new vigil. And, many of us do prescribe that. But, it's an uncomfortable, again, feeling to not have some objective findings that say, hey, this person's not sleeping well, or why they're not sleeping well. And perhaps it can point you in a direction that can help you better manage them. So we talked about, you're going to hear some examples later on about the depression. And, as we know, depression is so tied to insomnia, but it's kind of nice to have a test that can verify it. In terms of pain medication, for me, I don't have a high population of patients that are taking pain medications, but it is helpful to know that they're sleeping well and you're not going to subject them to problems such as obstructive sleep apnea, because they don't clinically present as having it, so you don't test them for that. But they do, many of them have sleep problems who are on chronic pain medications. So you can go to the next slide. Okay, so I'm going to just point out two simple examples, and I'm sure most of you have these patients. The first one is, is a young patient, and for me, again, this raises the concern. He's a male, 36. He has a mild depression, taking Celexa, and the question is his fatigue that he's complaining about real? Is he someone who's just working overtime? His sleep diary certainly could tell us those questions, those answers, but having a test like this can document whether or not, in fact, he's getting good sleep through the night. To me, it's very, very helpful. So it gives us some objective understanding as to his problem. In this particular case, what I found very interesting is Dan had suggested to me, and it wasn't my training prior to this, that if you looked at the non-REM to REM sympathetic arousals, those patients that had a higher non-REM versus REM sympathetic arousal index were more likely to be depressed. So in this case, it was very helpful to act as a talking point to the patient as to whether or not they may want to consider further medication beyond their Celexa that they were taking. I prescribed trazodone, and the patient did quite well. You can go to the next slide. Okay. The next slide is an interesting case because it happens to be my mother. My mother's 87 years old, who, because of my interest in sleep, obviously started to complain of sleep issues. And she had a history of being on Celexa for a while. She has a lot of medical problems, on a lot of hypertensive meds, and in fact has been taking chronic prednisone for her arthritis. But lately she had been really concerned because she didn't think she was sleeping through the night. What was obvious to me, not to you, but she had, her husband, my father, died a year ago, so she had more reason to be depressed. And she had been in and out of hospitals for some relatively minor infections. So when I asked her to take this sleep profiler, and I looked at the results, initially I was, basically feeling my mother was being more of a hypochondriac. She was overstating her complaints. Because she had a great sleep efficiency, 81%. But when you look closer and you see the percentage of REM that she had, it was quite dramatic. So, 40% REM at 87 is pretty significant. Where she should be, as the slide suggested, 29%. And, she also had, and it's not pointed in the slide, a shortened REM latency. I think it was somewhere like 20 minutes or 29 minutes that she got her first REM period. So clearly she was depressed. I suggested she increase the medication. She's doing much better. As far as the sleeping, she's sleeping well, and the knowledge that I told her that she's sleeping well helped her to accept the fact that it wasn't an issue that she had to pursue.
So when we went in and set up Dr. Hamburg's office, what is required to dispense this is very, very similar to home sleep testing. We've developed a battery of videos. We have a total of 6 videos that teach you different aspects of how to use the web-based portal. There's also we have a 6-minute patient video. Some clinicians are providing that for the patient to watch in their office before they send them home with the device. And then there's a simple, small front-back set of instructions. What's needed is really very little. It's very similar to the Aries. The patient wipes off their forehead with an alcohol. The device does impedance monitoring every half hour, which when you're doing technical review and the signal starts to look a little wonky, it's nice to be able to look down and know what the impedance measures are to get confirmation that there is a problem or that the sensor may not be affixed properly. The device can record up to 14 hours. If we recommend 2 nights of use, and so the patient essentially has to plug it in and charge it between night 1 and night 2, and they have to put new plastic sensors on. That's essentially the burden for the patient. As I said before, it's all web-based, so you're working through the actions, the reports, and troubleshooting. We have study status that helps track where that study is to be able to manage it if you have different people that are doing technical review from those doing interpretation. For researchers, we're able to export the original EDF file. We have people that are using the auto scoring and the system that we have. And in addition, they want to look at the signals in MATLAB so they can export the data. And also for people using it in studies, they can export all of the metrics that we provide into our reports into an Excel format so they're able to do all their statistical analyses. With what we call InsomniCare, to do this, and this is what Dr. Hamburg is doing, is he's essentially doing a sleep profiler study, and then he's reviewing the results with this patient in the consult. Built into the portal, we have the option to where you could continue and offer the patient online cognitive behavioral therapy using the Shut-Eye program. And when you order it through the portal, it allows you to monitor how the patient is doing as if you were doing a CPAP initiation trial. It lets you monitor when's the last time the patient logged in and did their last shut-eye training, where they are in doing their sleep diaries, how far along into the 6-week program they are, so that if you optionally wish to bring them back and do a second study to quantify how well they improved as a result of cognitive behavioral therapy, you could do that. So if you're working with a therapist already, you don't need to do the online CBT. We do have additional reports that provide comparisons of their pre and their post-treatment sleep profiler studies for those that might be interested. Again, this is all optional. I think the last thing that we need to talk about when it comes to commercial implications for this is billing and reimbursement. So the 95827 overnight EEG has been associated with sleep centers for many, many years, dating back into the 90s, where it was one of the codes that got used to bundle together what we now use as 95810 for overnight polysomnography. You can see that the reimbursement ranges considerably in Arizona and New York. They're reimbursed better than California, Florida, and Georgia. And what is reimbursed based on the payers varies quite widely, as you can see from California. So the reimbursement right now is from the example is from Dr. Hamburg in New York, and I can just let him comment on his experience there.
So far, when I first got the equipment, I was very apprehensive, and I got predeterminations from all the insurance companies, and so therefore it was a slow start because it takes a while to get that. And every one of them basically said it was not necessary to do a predetermination. And we have been reimbursed extraordinarily through, Medicare, from the Blues, Oxford. I think GHI is on the lower side. The unions have been paying, so it's not a problem, and it's something that it's definitely financially worthwhile.
So, and again, the point is that these billings are being submitted under the ICD-9 codes that we present above. So we're talking about submitting under depression or hypersomnia, those type of categories, with claiming that it's an out-of-office service. So everything about what we're doing is being accepted by the payers.
Craig had a question. I answered it online, but I don't have the answer. He had a question. Could sleep labs bill directly for this use of this device without necessarily billing it under physician? Well, you know the answer to that?
I don't know the answer to that because reimbursement is not our area of expertise. What our experience has been is that if somebody who is a sleep center or affiliated with a sleep center does the billing, that it will be there's much greater likelihood of reimbursement. So again, I think the most important thing from Craig's standpoint is making sure that he does have a clinician who is able to do the interpretation, who's boarded in sleep, and that should satisfy the criteria that the payers would expect for the amount of money that's being billed and for the service being provided.
I agree. I think it would be paid for. I do.
The last thing I want to do is just point you to at our website, www.sleepprofiler.com. It's going to, in the top section here is what you'll see. And so if you go under the Sleep Profiler help documents, it gives the scoring manual Dr. Westbrook talked about and all of the downloadable forms, the sleep diary, all of the other elements that are part of the system. If you go to the videos and click on that, you'll be able to choose and watch any of the videos. The first one is the guest exploration, and it's about a 6.5-minute video that provides a complete overview of how the portal works, how you navigate it, how you edit studies and whatnot. And then we also, if you click on guest exploration, it will provide sample studies that you can actually open up and look at the signals, and you can edit them if you choose, although your editing are not. So the last section I have are some clinical results of some data that we presented at Sleep 2014 and some additional analyses that we just presented at a regional sleep group here in San Diego a couple weeks ago. I know that we're already a little bit over, so we provided most of the information for those that feel they just wanted to get additional information. For those that want to stick around, I'll briefly go through this information now, and then we'll open it up for a Q&A. So one of the first things we were interested in, just like we looked at it for Aries, which is what is the night-to-night variability in the sleep architecture, with the interest of being able to understand, is there a first night effect? If we only send the patient home, and especially an insomnia patient, and they're only getting one night of information, how much might that be distorted based on them wearing a strange device the first night? We know with home sleep testing, there's a first night effect, and there's been reports for those who tend to be lighter sleepers of a first night for PSG. So here's just some plots of 35 patients where you can see the reliability. Surprisingly, the consistency of stage N1 was the greatest, and the least was REM. And essentially what happened here, looking at the bias, is people spent more time in stage N2 on the first night and more time in stage 3 and more time in REM on the second night, which suggested there was a first night effect. Looking at the cortical arousal, so we compute cortical arousals through automated detection. the pulse rate arousal index, the sympathetic arousal index, is similar to the one that we've been using for ARIES as a behavioral arousal index. You can see that the sympathetic arousal index, cortical and movement arousals are also fairly consistent night to night. The awakenings are not so much. But all of these are calculated and available. One of the other things we're interested in considering is there a first night effect was how well the self-reported information from the sleep diary matched the objective information. And when we look at patients who were on sleeping aids for the 2 nights that they wore the sleep profiler, you can see that patients on sleeping meds, their self-reported sleep efficiency, sleep latency, and WASO are very poorly correlated with the objective information. Again, not surprising, but we do see for those that were not taking sleeping aids that on the second night, their correlations improved substantially, suggesting that there was, in fact, a first night effect. So what we're starting to provide in our reports that for when people do 2 nights, we'll be averaging the data together and then making comparisons to the normative database. A couple of other things we were interested in was just looking at the differences in people who are on sleeping aids and not sleeping aids, and looking to see if the distribution of sleep with the sleep architecture is consistent with the literature to confirm that what the sleep profiler is measuring is in fact what you'd expect it to. So here, by way of example, we stratified people on sleeping aids, no sleeping aids, and sleeping aids, and we're seeing greater N1 for those on sleeping aids. We're seeing less N3 for those on sleeping aids, and we're seeing less REM time. Again, patterns that you would expect for those that are taking prescription medications. We also looked at patients who reported depression and found that we had less N1 sleep, less slow wave sleep, more N2 sleep. Again, patterns that you might expect by those with depression. We did not see the REM patterns, which surprised us a little bit. But one of the areas that we found that just popped in the data was looking at the differences in the pulse rate of patients who were depressed and those that weren't. And in the scientific literature, it's been reported that depressed patients have much greater heart rate variability during the daytime. There hasn't been much reported on ability during non-REM sleep, but not during REM sleep was quite substantial. So here you can see that the mean of the people during REM sleep heart rate variability for depressed and not depressed were similar, but the differences for the non-depressed and the depressed in non-REM sleep were quite significant. And so the example that Dr. Hamburg mentioned, where he was comparing the patient that had 24 events per hour during non-REM and 7 events during REM, the difference between those two is 17 events per hour. And that's one of those numbers that we look at. The difference between the non-REM and the REM is something that we believe is going to be predictive long-term in looking at those patients who likely have depressions. Another area that we're moving into with the sleep profiler is into the ICU. We've started using it to monitor sleep quality in patients who are sedated and mechanically ventilated to see if we can assist clinicians, those doing critical care, to be able to adjust the sedation levels in order to minimize the impact on sleep, to encourage or to reduce the time it takes to wean the patients off mechanical ventilation. So we'll be having a new sleep profiler app that will be out in a couple months that will be tablet-based, and it'll allow the clinician to stage sleep almost in real time for up to 24 hours. Well, I'd like to thank you all for attending. Again, you're welcome to go to our website, www.sleepprofiler.com, and feel free to contact either myself or Eric or your sales rep in the area. Dr. Hamburg and Dr. Westbrook will be available by email if you have questions about how it might impact your practice. And again, thank you all so much for attending today.